Okay, you can start us off with a prayer, Father. Before you go.
Sure, excellent. Once again, we welcome Dr. Rodriguez to the last lecture of this new cohort.
Yes.
As always, we begin with a little prayer. In the name of the Father, the Son, and the Holy Spirit. Blessed Trinity, we love you, we adore you, and we thank you for your many blessings. I want to thank you especially for the gift of this first cohort that started this journey with me about 15 months ago, last year in the fall. And so now we are 1 week away from graduation, and it's a great feeling for all of us. Bless this last lecture, that they may persevere. We welcome also, dear Lord, Dr. Rodriguez, who is giving this last lecture on a very, very special and important topic, very current to our society, to our culture. As always, we seek your inspiration, your blessing, that we may move forward your teaching with regards to bioethical issues in our times. As always, we ask for those people who are in most need of your divine mercy. In the name of Christ, our Lord.
Amen.
Father, Son, and Holy Spirit.
Amen.
Thank
Thank you, Father.
You're welcome. Thank you.
Okay. Hello, everyone. I'm going to put this on kind of a slide mode here so we can make them. There you go.
You want to use this share?
You ready? Did everyone get the handouts?
Yes. Homework.
All right. So I'm Dr. Sandra Rodriguez. I am an adult and geriatric psychiatrist here in the Miami Lakes area. I have a private practice, and I also do other types of mental health work. I'm also a member of the Catholic Medical Association, the Miami Association Guild, and the Catholic Psychotherapy Association, like Father mentioned. So in mental health, we have not only, obviously, the medical aspect of bioethics, but we also have the psychological aspect. And Father asked me to speak about mental health bioethics, and I told him, oh my God, there's a million things we could talk about, and there would absolutely be no time to cover everything. So he really wanted me to focus on the issues with the current issues, and just really focus on gender identity issues and physician-assisted suicide and euthanasia. So what I wanted to do very briefly, and I think Dr. Vizcarrono discussed this with you guys, right?
Yes.
The 4 principles, the core principles of ethics, and just kind of do a very brief review regarding mental health. So maybe we can have a discussion about this. The first one would be respect for autonomy, which is the patient's right to make an autonomous choice. But this one in psychiatry, obviously, is closely related to competence, which is a legal term. So if the patient is competent, then we assume they can make a decision that's going to be good for them, for a good outcome, and that they are going to be able to make informed consent. Now, informed consent in psychiatry can be an entire lecture. But it is a very important subject, and it's something that in daily practice, we have to be very aware that patients do have the capacity to make decisions because of this idea of respect for their autonomy, and they have to be able to make decisions and make sound decisions for them. Now, as we go through the other issues, we want to go back to these 4 principles, right, and see how they affect the other areas. For non-maleficence, I always say it backwards, non-maleficence is the duty of the psychiatrist of avoiding harm to the patient, obviously. So this one is closely related to the principle of, and the Hippocratic Oath, the first do no harm. And we're going to see this, again, closely related to the treatments that are being proposed for these two issues. For beneficence, and you guys have reviewed this too, is to prevent or remove harm and promote well-being. So what's a good example in psychiatry? The psychiatrist decides that the patient doesn't have the capacity to make the informed decision of whether or not to enter the hospital because the patient is suicidally depressed. So the doctor's duty is to prevent and remove harm, and therefore we make the decision to admit a person involuntarily. So those are big issues within psychiatry that I just briefly wanted to mention. But within the subject that we're discussing today, it'll come up in other ways. And the issue of justice, of course, and this is so broad, economic, social policies, mental health policies, access to care, and you guys are familiar with all of that. So there's, in order to stay in time, we're just gonna, that was just a brief review that I wanted to do, and keep those in mind when we're going over the other issues. So I'm going to start with gender and gender dysphoria. We're going to have some definitions, discuss human anthropology and gender issues, ethical implications, mental health treatment considerations, and then have a bit of a case discussion. Okay, and you're also going to see some slides with a lot of stuff on them, and it's just that I wanted you guys to have everything in there as far as like definitions and stuff, but we don't necessarily have to read through all of it. So the definition of terms for gender, and also I believe this, Dr. Vizcarrondo went through this with you guys. Gender is the psychological and cultural characteristics associated with biological sex and individual's awareness of their being male or female. But sex is really determined as it's a biological term, and it indicates male, which is in fact an X or Y chromosome down to the cellular level, or XX, which is female. And these are facts that then we're going to get into the ethics of, can we change these? Okay. And gender identity, we're going to talk about the changes in the DSM-5, which is the psychiatric diagnostic manual. Before, it used to be called gender identity disorder, and then it was changed to gender dysphoria, and we'll discuss those. Gender transitioning is someone who is undergoing the treatments to have a sex change, to go from female to male or male to female. And they usually refer to them as gender transitioning. And transsexual versus transgender. Transsexual is not being used as much anymore. And in all of these subjects, you know, we have to, I always enter into these discussions very reverently. These are very serious issues that are going on within our society. And the terms seem to change constantly. So transsexual, my understanding is that they're not using that term as much anymore, but that is considered the person that is going through the transition. Transgender can be someone who just identifies as the opposite sex, but is not necessarily undergoing the treatments. That is my understanding. So this is just so that you guys could see what the DSM-4 TR, that this was from 2000, They described gender identity as a disorder. It had the word disorder in it because it really is a strong and persistent cross-gender identification. They mention children. They mention the discomfort that they go through, and that the disturbance is not caused by intersex condition. That's C. And that's very important because we're not talking about someone who has ambiguous genitalia. These are persons that are XY and XX. It's not other conditions, okay? So it's strictly a psychological condition. And they did used to mention the specifiers of whether it was a male sexually attracted to males, or whether it was sexually attracted to females, or both, or neither. So they make some distinctions here. Now in the DSM-5, they even took it out of the disorder list. So they took it out of the sexual disorders and made a separate chapter for gender dysphoria. This was in 2013. And well, let's go through it. So it defines gender dysphoria as the distress that may accompany the incongruence between one's experienced or expressed gender and one's assigned gender. Although not all individuals will experience distress, many desire physical interventions by means of hormones and surgery are not available. So their distress is coming from not being able to get the treatment. There is a very big difference here, right? So number one, not under sexual disorders. The subtypes of identity disorder based on sexual orientation, that was deleted. They no longer find that important. If it's female who wants to be a male, but is still attracted to males. That differentiation went away. It's very confusing. It's almost even a little difficult to talk about because we have to keep track of what are we saying here. And the terms keep changing. So they took that out, and they don't seem to think that that's important. And when I say they, I say the people who decided to write the DSM-5, which is a whole nother class in itself too of how these changes came about, etc. So it also separates the diagnosis of gender dysphoria for children and from adolescents and adults. And the characteristics of gender dysphoria vary with age. Many children with gender dysphoria outgrow it as they age. At least they mention it in the manual.
And this is appeared to in the maternity, the gender assigning at the work.
Right.
If you make a screening, a baby, they say to be gender assignment at the time of work. So this is the mom decides that baby because it's a boy, but she wants to do a male or female. She can
assign it. Yeah.
She can assign it at sex. Yeah, that is.
If the child starts to verbalize as early as 2 years old.
Oh no, but then it was at the day of the born. So since
like,
assignment.
It's like, I think it's a girl, it's gonna be a girl. And that's it.
That's it.
Yeah. Yeah. That's what we're dealing with.
And
we'll come to find that, you know, if you're thinking about non-maleficence, beneficence, what are we doing here? Is this going to be good for the person? Is this going to be good for society at large, etc.?
I don't get what she was explaining to me. That
a mother assigned
the gender
when the baby was born.
Yeah. Well, that's not in every country. That depends upon where you are. There's some places that's what they do. They'll say what sex is this? Is this baby? And she'll say.
Yeah.
But we don't do that.
Here in USA, yes.
Well, I've never done it. I've never seen it done, and
Well, yeah, I was in the kindergarten, was in training.
And if-
that's a way.
If there's ambiguous genitalia, they do have to
They
choose.
were screening. They were screening. No, because there's a maternity, and then they say screening. They were asking sex assignment, and they said what? And they, oh wow, I heard that before. So there's a sex assignment on the wall.
Yeah.
They put it in the paper. That is a format.
Yes.
Wow.
More commonly, if it's ambiguous genitalia, which is a medical condition, and they have to choose, and then later on, as the child develops, then they can try to figure out which one exactly. But now we have, like on Facebook, there's, I don't even know the number. It's like
15 different
genders.
genders.
Yeah.
15
So,
different ways to
In
characterize it.
Spain, they already put in place, yes, more than 9 genders.
yes. Yeah. So, and I always think, what's the end point to all of this? Where are we going with this? What's the point? And it's just a lot of confusion. It's the very first thing that if we're looking at the spiritual aspect of it, but that's a whole nother story, right? So, so there are a lot of critiques. This is the problem with this, is that the distress doesn't necessarily result from the condition, but from society's unwillingness to give those with gender dysphoria the medical assistance necessary to alter their sex, right? So it's not that I'm upset because I feel like I'm a male trapped in a female's body.
Yeah.
But that's not what's making me upset. What's making me upset is that I can't get the treatments that I need. That's what the DSM-5 was saying. Okay?
Yeah.
Very radically changed.
In other words, it's the responsibility of the physicians to change,
The
to mutilate your body.
Right. And if you don't, then you're not honoring my autonomy.
My autonomy.
Exactly.
But you're affecting my autonomy.
Exactly. But then it's like, what about
Oh,
do no harm? What about, so
That's the same
that's
thing.
why, yeah.
Do no harm means I'm not going to do harm to you or you.
Exactly. And what I proposed and what the National Catholic Bioethics, that's where I got most of my information from. What they propose is that it's not good for the person. Like if we look at outcomes and they are bad,
Yeah.
what are we doing, right? So we are causing harm.
Yeah.
So
You are a killer.
it's a topsy-turvy world.
Well, you're dealing with people who have an agenda, and they're trying to push that agenda on the rest of us.
Mm-hmm.
Right?
Yeah.
So that is, so everybody has to follow.
And if you don't, then there will be consequences.
Right.
Yes. So then let's look at the human anthropology and the ethical side of. So that was the diagnostic side, and so the ethical side of this. As far as Catholic bioethics, we need to mean what it means to be a human. Understand what it means to be a human person. And the body and soul unity that I hope you guys should be teaching me about this part. Okay, so there's the body soul unity. The two principles of this union cannot exist independent of each other. So a person's sex is manifested by the body in accordance to how the person was created. The soul is neither male or female. There is no evidence that the soul is male or female. The body determines the sex down to the chromosomal level. Gender ideology proponents suggest that there can be a male soul within a female body and vice versa. And we absolutely cannot accept that because the soul is not male or female. The spiritual powers of intellect and will have no gender as well. And like St. John Paul II said, the human body expresses the person, and we can't separate them. Once we separate that, they cannot exist. It's just impossible. So this is our understanding of the issue, correct? And what are the ethical implications? Well, gender transitioning is an act against the person's own good. So it's a rejection of the self. It's considered, in our eyes, self-mutilation.
Yes.
And the medical and chemical harms that come from it are they're very evident. It's just like we're a very blind society to completely ignore the evidence that this is bad medicine. I would argue just like oral contraception is bad medicine and we've ignored it for many years, this is the same thing, especially in children. And I didn't mention children because I'm an adult and geriatric psychiatrist, but children do go through gender fluidity, and 95% of them, up to 80 to 95% of them, get over it. But now they're being identified, and there's pressures to start treatments in a kid that's very, very likely going to grow out of the identifying with the opposite gender. So the moral repercussions, it does not ultimately contribute to human flourishing, and we'll see that. It leads to moral repercussions in the practical order. So this is all going back to the 4 principles, right? What are we doing? Lack of evidence showing medical improvement with gender transitioning. There's lack of informed consent, because really, and parents cannot make a true informed consent if they don't have the information. A child who's 9 years old cannot make true consent. So you can sign a paper, but you're not really understanding what's going on or what the consequences will be in the future, because the doctors are not informing. So it's very concerning, and truly a violation of the medical standard to do no harm. So in mental health treatments, there's many controversies. And this is actually from a transgender statement from the NCBC. Persons claiming to be transgender must be accompanied on their difficult journey with true charity and should be offered ethical, effective therapies based on sound anthropology and scientific evidence. This is the ideal. Is it what's going on? They would argue that yes, they're being ethically, and so we are at complete odds with these treatments, and it's difficult for both sides to understand each other's side.
Right. That's what happened the other day. They were voting against therapy to this kind of patients.
Yes.
To be
children.
In children. Oh, okay.
Yeah, for children.
So they don't give the opportunity even to receive the counseling.
Even if you wanted it.
Even if you.
Yeah. So there's the controversies for the medical and chemical treatments, and the informed consent for that and everything that's going on with that. And for the psychotherapy treatments, there's even more controversies, because really the psychosocial and environmental underlying ideologies really do point to psychological interventions. So there's been so the background to why a child would start having these symptoms would be parental psychopathology, family dynamics, adverse childhood events, sexual abuse, trauma, social reinforcement, which is now a really big catalyst to all of this, and social contagion, basically, to facilitate. It's facilitated by mainstream media and by social media. So the controversies that you're mentioning regarding reparative therapy or conversion therapy versus transition affirming therapies, which is, okay, I'm going to see a therapist, but it's a therapist to affirm and say, okay, this is what you need to do to be able to get cleared, to be able to go into the surgeries. So there's those polar opposites, right? None of them have evidence that anything works. There's no controlled clinical data to support specific interventions either way. And this is more specifically to childhood. Joseph Nicolosi and several people have been practicing what they called reparative therapy and conversion therapy. And that's very controversial, even within psychiatry and psychology. We're not in agreement. There is data from what they've done, from their experience, but there's no clinical studies. So they have successfully been able to help a family and a child resolve those issues and not continue to gender transition. But now there's a very strong political and legal, and it's going on here in Broward.
And in Miami-Dade.
And in Miami-Dade, to not be able to offer these treatments for children because they consider it abuse, while we consider it abuse to allow it, because we know that 95% of them are gonna. So there's that. Then there's obviously the hormonal and surgical treatments, and again, very little evidence to show that anything is going to improve psychological. So remember, these are treatments. They're proposing that it's a surgical treatment for a psychological issue, and it's not working. And there is evidence there that it's not working. So most studies show very negative outcomes.
So if it's not working, they found the evidence, why the government continue allow it to do it? Because if you prove that there is something that's not working in the society, that's my opinion.
Yeah.
You know, so why you allow it?
Somehow.
The government responsible.
No, because we're a free country and you can do what you want.
Exactly. And somehow the ones like Caitlyn Jenner are glorified and glamorized, and so they would want
They don't
us
tell you
to
anything about what's going on in that person's inside life.
in the negative.
Okay, so everything is out there in magazines and the pictures and so on.
Yeah. But the negative outcomes you don't hear about.
You don't hear anything about what's going on within their lives.
Right.
So do you have to give treatment to the patients?
If someone were to show up to my practice, yes, I can't turn down patients because of any reason. If they come to me, I would be suspicious that someone's trying to sue me. That's the first thing. This is how the world is now. Yeah. I would absolutely offer them treatment, but I would disclose,
Where are you coming from?
this is my belief, and I believe that this is not good for you. This is not going to eventually
Help you out.
help you out. You're still going to be depressed. You're still going to be suicidal. There's still issues going on that you're completely ignoring. So do you want to continue treatment with me? I'll treat the depression. I'll treat the anxiety. I'll treat the the psychiatric issues related. But the psychological stuff, it's not going to be addressed with a drug or with a hormone or with a surgery. So, and that's good medicine.
But the physician, the provider is going to be penalized, something about that?
If the person wants something that I don't want to provide, I disclose and I tell them, I'm not going to affirm, I'm not going to say this is good for you. I think this is bad for you, but I can treat everything else. Such as like with someone with same-sex attraction, and they know that I'm a Catholic psychiatrist and they see a crucifix in my office, they're going to know, okay, this is what she believes, but I really need treatment for my depression and well. And I can say, I believe that your depression has something to do with the sexuality issue, but if you want to just ignore it, I will lovingly treat you as well as I can. You know where I stand. So sometimes I leave, sometimes I stay. For transgender, I haven't had that issue. So I just haven't had someone who either transitioned already and is still having difficulties or is in the process of doing it. I don't see children, so all these kids that are coming up, I'm not seeing that. So.
I saw that one day with a therapist, a social worker that I'm a friend of, a young boy that wanted to become a female. That was so sad.
Mm-hmm.
Maybe he's like 13, so the mom was like crazy, you know, to find help for him.
So I end up helping the parents more. It's all I can do.
Clothes that he wear is a girl clothes to come to the therapist.
Mm-hmm.
That was like killing me.
Yeah, and and again, very reverently, we have to do whatever we can. But I mean, I believe that something has to come to a head. I mean, let's look at the little video here. I hope it works. Okay.
By the way,
does this have
excellent. I have this.
Sound?
Excellent.
Isn't it good? Yeah. Does this have sound? Will you guys be able to hear this?
Yeah. Play it. And go to the middle of with the mouth.
Yeah, it's not him. Maybe it's loading or. Oh, because this goes over everything very eloquently. Maybe I can.
So you want to answer this?
What is what?
I wonder if it does have
Comes out, I think once or twice a year.
sound.
And I got this.
Is it on YouTube?
Reference for this and
Mhm.
sent for it. And the book is very good. This particular subject, this one subject of it, but the whole book was devoted to this subject.
Is it on
The
YouTube?
whole
Mhm.
journal for that month or that quarter was all about the dysphoria.
Was it? It's in the New Atlantic.
Mhm.
What?
Oh, that's what.
There it is. So I don't know if we have sound.
The volume maybe?
It's
Maybe the sound is mute. Yeah.
Mhm. Like there's no speakers.
yeah, on the right hand, on the bottom, as I'm looking at left,
Yeah.
there's a speaker.
But
No, at the bottom of this thing, of the colored thing, to the right.
Yeah, it's already up.
no, the speaker of the
Oh, it has some.
I guess 90% of us would be okay with it. Or you could just live translate it as you go. Is that okay?
Yeah.
Okay.
I mean, I think it's probably just what do you call that?
So it's a journal. It's a journal.
They
Yeah,
might,
I
they might
think-
have to live translate. There's only 2 people.
It's not.
But I don't think there's speakers.
I really didn't pay attention to that.
So yeah.
Oh.
So this was just like a review of all the studies that they had available. And it's actually a firm that does scientific reviews. And And do you guys have these slides? Do you have access to the slides?
Yeah.
So then maybe you can watch the video later. But they actually go through the studies, and there's a psychiatrist and yeah, definitely I can hear it. And he's also an epidemiologist.
Okay.
So, you know, and what they're saying throughout this little video is that really we're studying the evidence, and it does not seem to show that that these treatments are helping. So it was just a good review, but you know, we won't waste time on it if we can't. But you can watch it when you get the slides. Okay. And so there are studies. This one was a longitudinal study from 2011 in Switzerland, and you can see the results are not good, right? 3 times higher risk of psychiatric hospitalization, 3 times higher risk cause of all-cause mortality for people that have undergone surgical treatments, increased risk of being convicted of a crime, and 4.9 times higher risk of attempted suicide, and a whopping 19.1 times more likely to complete suicide from the general population. And you know, this is
That's crazy, man.
a cohort, you know, long-term follow-up. This is a good study. So
It was, I don't remember if in this study, there was a cohort that was not treated, that did not have transsexual surgery. I think that's the one of
and
the
they
problems
controlled
with this.
for
The control, there was no real control population other than the otherwise normal population.
but they controlled by at least like prior psychiatric hospitalizations. And
That
stuff.
is even comparing to a group of transsexual persons who had not undergone surgery. I think that's one of the big problems is
If they won't do that.
Yeah.
To be able to really compare apples to apples, of course. So, but overall, it's just bad outcomes, right?
really sad.
So let's see, what else do we have? So we have, this is Dr. McHugh. He was a chief psychiatrist at Johns Hopkins. And he really, you know, this was from a LifeSite article, and he's quoted as saying, we really are doing experiments on the children that we're putting through these treatments. We should tell everybody that this is an experimental procedure right now, and that the experiment is not being done with controls, and it's not being done with clear statements to the parents that we can't tell what the outcome is going to be. Because if you leave them alone, 95% will just live a normal life with their actual gender and sex aligning. So to me, that's the biggest issue would be the true informed consent, right? So average treatment start at 9 years of age.
That's to stop puberty, so they won't go through puberty.
To stop puberty. And a very large number of these families are going to find that they've been misled or misdirected. And so there's the article where you guys can go read about that. This is a case study. This is the typical case study. I just wanted to kind of give you guys something coming from the DSM. Like, this is from a book for lay persons wanting to explain. And so you'll see in this case study that they go through the narratives that everyone wants to hear, right? So it's the narrative of the person that was married, but from a very young age, they they noted that, there was something about the kid, maybe a little bit different. And so it just goes through the whole process. And you can note that this person then, even though he was married, then he starts feeling like, no, I'm living in a lie. This is the narrative. This is the one that we keep hearing. This is the one that they want us to really understand and take in and be charitable and be like, well, poor guy, he feels like he should be a woman. Let him do it. Why are you not letting do it? So he goes to a therapist and everything. Sought treatment for mental health. After he talked about his life, then he begins to say that he has a sense that he is Christine, and goes through the whole process, and finally, to gain the courage to tell the wife, and goes through the whole thinking process of, let's affirm this. I think what you need is you need to change and live as a female, and affirming that. And at the end, it's like, oh, the hard transition. We know it's going to be hard. It's going to be hard to tell the wife and family. And that's where they leave it. They don't say, then, I was looking for case studies so that we could discuss them.
See what happens. What happened after the fact?
Yeah, it's all like, well, and then
what really happened, not
exactly.
not what the press wants to know. What really happened?
Exactly. What really happens
What sickness that inside my body.
is, and really suicide, further psychiatric issues, that's what happens. The person does not avoid suffering.
Goes too deeply.
Exactly.
He getting suffer more. He getting suffer more than he was a male than a female.
Yeah. And actually, looking for videos and stuff, there was a young man in, where was it, in England, that at the age of less than 18, so maybe like 15 years old, decided he wanted to be a girl. And it was a big production, and he went through it. But then he was severely depressed. So then he changed back to being a male. And then he was even more depressed, and then announced, well, I want to change back to being a female because that's really what I'm supposed to be. And maybe now I'll be happy. After going back and forth.
Two such strangers. And who's paying for all this? Not that I don't think that, not that I think that's the most important thing. The most important thing is what's going on in you.
Right.
We're not addressing. Nobody's really taking care of you.
No, we're not addressing it.
They're taking care of your body, but they're not taking care of your head.
Exactly. And if we try,
or maybe you won't let them. That's another thing.
But if we try, at least with children, they will come after you. If it's against the law to provide true gender affirming treatments, it's considered illegal because they've switched it, right?
Mm-hmm. No, it's okay.
So in New Jersey or in New York, I believe, it is those bills passed. Like a therapist cannot risk their license, even if it's like the kid is like, but I don't want this. I really don't want this. They can't get the treatment they need. So this is where we are. I did have another video. There is a, this looks like it was from a Christian production. I don't think it's Catholic Christian, but they have this movie and you can watch the trailer and everything. And it's people who, now bringing in the spiritual aspect of it, people who have gone through the transitions and have found that they're not happy and and basically have found consolation in the spiritual aspect of it, that we're created and God doesn't make mistakes and all of that. It's a really nice. Hello.
So, do we have anything about the kids already raising in a couple with the same sex?
Mm-hmm.
Because any psychological and psychiatric consequences of that?
Yes, there are studies.
Okay.
There are studies. And of course, like any subject, some studies are like, oh, they're totally fine and very,
Yeah.
and some studies are like, oh, there's trouble. But then they get so criticized and ostracized and they never get published.
Because when you mentioned the social, my daughter, my 13 years old daughter yesterday, we were having dinner, and she said, Mom, you know that Nickelodeon has one of the show where a boy, they're raising two men are raising a boy. I said, yes, and the same Disney doing the same thing, but this is biological impossible. She told me nothing. Said, yes, you're completely right. This is biological impossible, but that's what they want to sell to everybody. That this is normal and this is it. So they are confusing the kids. She said,
Well, so that's the whole idea. So that they take them away from you and the way you want them to think and put them into, it's a communist kind of way of thinking.
yes,
That's what it is. It's a communist way of thinking. You take the children away from their parents and you indoctrinate them.
Even Disney now.
But just even,
Crazy.
oh yeah.
Crazy.
Just because
So-
of state's property.
Mm-hmm.
I just
Yeah,
thought
That's the way they look at it.
The mental corrupt wants to consign other mentalities, like they want to spread the corruption of their mind to other people. That's psychology, psychiatric is like that. So these people wants to pass to other people his mentality because the mind they are corrupt. So psychology
The
is
the
like,
proponents, the people that are,
yeah. So
that
it's
are-
something like
it's also a very liberal way of thinking that to disregard any tradition, disregard anything that's even remotely religious is not standard of care. That because people are suffering from this, then we have to do the treatments that they need. So from the American Psychiatric Association standpoint and the American Psychological Association standpoint, they're like, no, this is a disorder. But now they're saying the not being able to get treatment causes the disorder. So we need to be able to give treatments. So yes, they are absolutely saying, this is the treatment we have. This is what we're going to do, and anyone who dissents from this is the whatever you want to call it, bigot, sexist, misogynist, everything
I'm
bad.
talking about, like, for example, evil likes evil sins.
Right.
So corrupt people likes everybody be corrupt too. This is the kind of mentality, like, they want to spread around the world. About people.
If we're talking about spiritual sense, I believe so.
Mhm.
If we're talking about the spiritual reality of spreading error, yes,
For
absolutely.
example, a person who has HIV, they want other people who has HIV.
Uh-huh.
So
And they don't care, and they have unprotected cells.
That's what I'm saying. I'm thinking some people who has probably mental problems, they want to spare corruption sins, but this is some kind of mental. They want to, like people who have some kind of disease, they want to.
They
And
want to
what
justify themselves.
no, what
And
they're
what better
saying
way?
It's an agenda. Somebody is
Yeah.
behind, people behind it.
and what better way of doing it
and they
than to
using
use the
all the
American Psychiatric Association?
To manipulate the organization.
Yeah. So in the 70s, this movement started when they took out same-sex attraction as a disorder as well. That used to be considered disordered, and then they were like, no, this isn't a disorder.
Mhm.
You can be same-sex attracted and be completely psychologically
Yeah.
happy and sound and have an awesome life.
Yes.
So now it moved further into, you can have the idea that you're living, a woman trapped in a man's body and be completely healthy, psychologically sound. It is not psychosis. It is not body dysmorphic. That's super dangerous. We are literally telling people, you're not, body dysmorphic is severe. It's like people really, really think that they look a certain way, and it causes all kinds of problems. Well, I would consider this to be a lot like body dysmorphic, but they adamantly say, like, no, this is not like body dysmorphic. This is not psychosis. This is a healthy individual.
Mentally and physically.
They just identify with the other sex.
So it doesn't fit even in the definition of health. It has to be physical and mental. I mean, it doesn't fit actually. You can't define a person who doesn't feel mentally that the body, it belongs to what he feels. And another thing is very rooted in feelings, not in conscience, not
chromosomal
exactly.
evidence.
And the feelings change one day to another.
Especially with kids.
Exactly.
Yeah. So it's not good news, but especially for psychiatrists and psychologists and therapists and family therapists, marriage counselors, I will say this: it's a big industry.
Oh, yeah, that's what I'm
Absolutely.
Yeah.
Someone's making a lot of money. And in this, in the trailer for this movie, someone mentions that it's like the black market of surgeries. Like, in years past, they would have to go to other countries. So it's a very, it's an industry. It's a
business, big money.
Yep. All right, so you guys want to take a break?
Yeah.
Okay. Let me see. So it's pause. All right, we're back. And we're going to talk about the physician-assisted suicide and euthanasia portion of very focused on the mental health issues. This is another one that it's a very big subject. We can't discuss every single aspect of it, so we're going to try to focus on the bioethical and mental health issues. So again, we're going to go through some definitions, ethical implications, treatment considerations, and we'll go through a case discussion and some talking points. So euthanasia, and this is maybe something that we can pause and really define, is death caused by intentionally, so it's by intentionally caused by the doctor, by a lethal dose of medication and administered by the physician or nurse. Euthanasia can be voluntary or involuntary. Voluntary is when the patient has awareness and does consent to it. Involuntary is when the patient has no awareness and does not give consent, but the physician or healthcare provider administers a lethal dose. So that's euthanasia, and that's not legal in the US. It's legal in the Netherlands, Belgium, but here in the US we have not gotten to that point. And the proponents very specifically avoided starting with euthanasia because they knew that the American people would absolutely reject it. So they started with proposing physician-assisted suicide, which is death caused by an intentional lethal dose of medication, and it's ordered by a physician and self-administered by the patient. So we have Oregon, Montana, there's a few others, I think DC, there's like 4 or 5 at this point, states, and some other states that are already considering.
Didn't it come up for vote here in Florida?
It did come up here for vote,
It
and
didn't pass.
here it's been rejected, and the Florida Medical Association and the American Medical Association. The Florida Medical Association, we have to work on them not going neutral on it, because the American Medical Association used to be against it, but is now working toward changing their opinion to neutral, which means that'll be the end. Yep. So, what euthanasia is not commencing treatment that would not provide benefit to the patient. That's something else. Or withdrawing treatment that has been shown to be ineffective or too burdensome, or that is unwanted, or the giving of high doses of painkillers that may endanger someone's life when they have shown to be necessary. So all of these principles are really, euthanasia and physician-assisted suicide are separate from the life support issues, right? Providing artificial administration of nutrition and hydration, cardiopulmonary resuscitation, DNR orders. There's now pulsed. That's a whole nother talk. We won't get into that. Those issues are really important, and they're important topics, but really what physician-assisted suicide is a separate issue. So in Oregon, you have to move there if you want physician-assisted suicide. You can't just go visit, okay? So that's just a little, we'll see with Brittany Maynard that this is what happened. So if we look at the ethical considerations, we obviously have the Hippocratic Oath, which the original one said, I will give no deadly medicine to anyone if asked, nor suggest such counsel. This has been eliminated from the medical Hippocratic Oath, the modern ones. It's been eliminated.
Yeah. It's not the Hippocratic Oath, that's gone.
Yeah.
Gone.
You have to
It's just like
it's different.
nice promises. It's not the core principle of do no harm.
I was reading the new Geneva, the modification of the Geneva Oath, which is the one that is more common. And there, I read it early this morning, but there it says, I will do no harm to any human person. I thought, oh, that's interesting.
And it's up for
It's been approved by
discussion.
the World Medical Council
Mm-hmm.
or the World Medical Association or something like that.
Mm-hmm. And
So that was kind of interesting. I thought, well, that's a step back towards having more respect for human life.
exactly. But then it'll depend on the
Well, yeah, we know that.
because they
At least
now they
here,
consider human
it means
dignity to be able to die with dignity. So it's the play with the words.
Oh, yeah.
So, and really this issue, and I think really the transgender issue too, puts at odds the core principles, right? You're putting patients' autonomy, assuming the patient is competent, because in physician-assisted suicide and euthanasia, as you'll see, Father Chofi is going to give you a case report where I discuss that more in detail, where at least in Oregon, they don't really assess for mental health issues. So the person can be considered competent, can be considered to have the capacity to make that decision, but as a psychiatrist, if someone is depressed, I'm going to say they're not competent, right? To make they're depressed. Depressed people get suicidal. So it's the game with the autonomy and competence, informed consent, and with maleficence and beneficence, are you causing harm? Are you not causing harm? Is the patient considering this because of their own judgment, or is it because of their family? So there's coercion, there's so many different levels to this that it's just, like I said, I mean, we could talk about this forever. So with the bioethical considerations, through the Catholic Church, through the lens of the Catholic Church, which is why we're here, their Sacred Congregation for the Doctrine of the Faith did put out an official declaration on euthanasia, and this was in 1980. So I just wanted to include that there. You guys can go over it. I don't think that there's anything here that we all don't already know and you haven't discussed. I think it's quite obvious. We have to respect human dignity. We have to respect human life. It is never permitted to kill anyone at any time with any condition. It is just the voluntary causing or the helping someone to kill themselves is not bioethically sound, right? And I think the last sentence is one of the most important ones that, and is also something that you'll see in the case study, that the plea of the gravely ill person is really sometimes, and I would say most of the time, it's not, they're asking for death and should not be understood as implying a true desire for death, but rather an anguished plea for help and love, right? So we have to see this as, this is a suffering person. Yes, they're suffering. How can we alleviate this suffering without having to eliminate the person? That's the bottom line. But we are up against a wave that is just extremely difficult. People are really being exactly. People are really switching when they do the polls and stuff, and who knows if we can trust polls, but a lot of people are saying, well, yes, I want to die with dignity.
But dying with dignity doesn't mean you have to have euthanasia.
Exactly.
Or physician-assisted suicide. Doesn't mean that at all.
Or going back to the principles, doesn't mean that I, as a physician, have to help you. Yeah. Why do I have to be involved in it? I studied 25 years to help you not kill yourself. So we are up against some serious stuff. And it is, and I always think of the spiritual aspects too. I mean, this is purely spiritual. The underpinnings of this is just death. It's just death. So again, here's a slide with a lot of stuff on it. You guys can go through it. Religious directives for Catholic healthcare services. This was from 2009. And it really just explains the ethical issues that even at Catholic institutions can never condone any euthanasia or assisted suicide. I wonder how they do in Belgium and the Netherlands. Like if it's a Catholic hospital, do they have to provide euthanasia if someone wants it?
But there is one Catholic hospital that's now given into it. It's now run by, well, I don't call it Catholic, I don't know. It's run by brothers, and they have finally acquiesced.
Mm-hmm. Yeah, because it's a strong battle. And it's very difficult to, especially in a country where it is legal, and how are you going to stay open and not provide something that they're making you provide? It's difficult. So really the solution is the solution that they would want, that Catholic institution closes, right?
Right.
So there's no Catholic healthcare. And that would be the part of the end game, right? Because we're the only ones that are saying, this isn't okay, right? So what else? So you can go through those. I mean, in my opinion, these are obvious things, right?
Yes.
And we have to have the Christian understanding of suffering and just deal with it instead of avoiding it, right? So the mental health treatment considerations are going to be, first, we look at why would someone, so speaking of physician-assisted suicide, because that's what's legal in our country, why would someone choose assisted suicide to begin with? From the psychiatric standpoint, a lot of cases, people experiencing a tragic death, watching or having to care for someone that didn't have good palliative care or good hospice, and they're like, I don't want to suffer that. I'm not going through that. I just want to be able to calmly kill myself and everyone's going to be okay. Witness of terrible suffering, fear about suffering and pain, fear about loss of control. The biggest one probably is fear of being a burden, and the loss of quote unquote dignity, like we were saying, and really depression at the end of life. It comes down to that.
Dementia.
Even dementia, yeah. So, when we look at the different issues, there are several different issues, and the terminally ill do get depressed, and it's a kind of a different diagnosis. It's because it's hard to differentiate the physical symptoms from just the physical symptom of the illness, for example, versus someone who doesn't have a terminal illness and is depressed, looks a certain way, feels a certain way, has certain physical symptoms.
Yeah.
So it's a little, the diagnosis is a little hard to do, but we can't just assume that just because someone has a terminal illness, they are going to become suicidal. It is not usual. This is not the norm. But, right, the proponents would have us think that it's the norm. Because I have a terminal illness, I'm not necessarily depressed, but I do want to die. It's again, the reasoning is just a little upside down. So depression is strongly associated with the desire to hasten death in the terminally ill. Once depression is treated, 98 to 99% change their mind about suicidality. And even when recognized, and this is we have to be very careful with this, even the doctors kind of fall into that thinking of, it's understandable depression because he's terminally ill. But it's not. Suicidal thoughts are never normal.
Why don't they treat that?
Well,
I've seen that so many times. It's like, can't you give them something that just makes them feel a little bit better?
Right.
Oh, they don't need it.
Right.
They do need it.
Yeah. Yep. And it's but it's understandable.
That's not the answer.
But yeah, it's understandable, but suicidal thoughts are never normal. But they would have us believe that they're normal. That's the hook, because then you can go forward with the legislation and everything. And in fact, not even call it physician-assisted suicide, it's physician-assisted death, because suicide has a negative connotation.
Exactly. Yeah.
So this is where we're at.
Physician-assisted death.
Physician-assisted death or death with dignity. The wording has gone.
So unknown.
Yeah.
So,
Yeah.
Bizarre. I don't know what words appropriate to that.
And in fact, when I published the case discussion, and it has physician-assisted suicide everywhere in the little article, the Compassion and Choices lawyer emailed us and said you can't use physician-assisted suicide. And so I had a email back and forth, and I was like, I'm a psychiatrist. You're not going to tell me what I'm going to call something. Suicide is suicide. I'm not a lawyer. I'm not going to tell you how to use a term. So please, we're going to continue to call it what it is. Suicide is suicide, whether it's this way or that way. You can't just change words. I've been studying my entire life to do this. So it was kind of scary, but you know,
That's the whole purpose, that's the whole point.
Yeah.
To have the attorney call you. Usually when the attorney calls you, most people will freak out and back off.
Mm-hmm.
But
Yeah.
these people are
I just
experts.
silent
It's a form of
coercion.
coercion, yeah.
Yeah.
Bullying, really.
Bullying.
Professional bullying.
It really was. It really was. So, you know, when we look at late life depression, which is another subject, right? So there's the terminally ill that we're going to assume that they want to commit suicide because, oh my gosh, you know, it's normal. They've had a good life. Then there's the person who is not terminally ill, but has late life depression, and it's very hard to identify. It's hard to identify because the criteria that we have for depression is for like a young male, you know, not a 90-year-old lady in a nursing home who, you know, has lost some faculties, or, you know, the being able to diagnose depression is something that you have to do very carefully, right? It's the diagnosis isn't as easy as with a young person that it's very, very obvious. So, you know, you would have people who say, okay, well, she's at the end of her life. She's had a good life. She's asking for physician-assisted suicide. We need to be able to give this to this person. When, as a geriatric psychiatrist, I would say, this is a geriatric depression with suicidal thoughts. This isn't just like, oh, I want to die because, you know, everything's great. I've done everything. I'm ready to go, and I want to do it quietly and comfortably, right? So that's another big issue, and that the laws don't account for that. The laws, in fact, discourage people from getting psychiatric evaluations, because then they'll find out it's a depressed person. And then you have the question of, oh, is this depression with suicidality? Or is this really a person who should be able to make the decision to kill themselves? So tricky field. And so we were saying the treatment considerations, we can have pharmacologic interventions, no matter what age, no matter what the situation, there's pharmacologic interventions that could work.
How does this one work?
I'm sorry?
How does it work? The pharmacologic intervention. How does it work?
For example, if we have a late life depression, like the example of the 90-year-old lady in the nursing home, and she's depressed, we can certainly try an antidepressant.
Right now, I have my situation with my mom. She's 76.
Mm-hmm.
She is in a high depression,
Mm-hmm.
and this become a burden for me because she rely on me to do everything. When she has a palpitation, never stop.
Mm-hmm.
She has a fear.
Yeah.
And right now, I'm supposed to see the doctor on Monday to see if he can refer me to psychiatry because, you know, he's been going on to that.
Yeah, and obviously, you know, this is just like the mental health part, but before we get to here, there's been a whole medical workup done, right?
They sent her so many, she just come from the Baptist hospital because of palpitation. She has fear.
Yeah.
She has so much fear.
Yeah.
You know? And then now, for me, it's really hard because everything's on me.
Mm-hmm.
You know? So the doctor just called me on Friday that she has to see me to see if we can send her, you know.
To at least get an evaluation.
Yeah.
Because no matter what age, it can still be the thyroid. You know, you still have to rule out medical stuff, but older people do get depressed and they do get psychiatric illnesses, but most commonly it's caused by something else. Most commonly. So, so the palpitations, you know, they have to do a cardiac workup and make sure it's nothing, because then their medications can make things worse for sure. Okay, so that's why that's another subject that I'm very passionate about is, you know, the prudent use of medication. but it's still a tool. We can still use it. Like if someone is suicidal, we would want to be able to offer that instead of offering a medication that's going to cause death. It's very absurd. So, but yeah. So there has to be a whole workup that goes before it, but yes, older adults do benefit from medications at times. And it depends on the situation. So there's also psychotherapy, family therapy, of course, within the context of a family member that wants to commit suicide. What else is going on? What else is going on in that family? Is there someone coercing? Is there someone waiting for their
life insurance?
For their life insurance? Is there? There's all kinds of stuff. I would be so worried to live in a state that lets this go on, because it can. So, and yes, and there is therapy for older adults as well. Okay. And of course, there's palliative care. That's very important. And it's the article that I gave you guys. Really, if you alleviate, and this has been shown in studies, if you alleviate the physical symptoms, if you alleviate the nausea, the vomiting, sometimes even positioning, people with dementia can't express that they're uncomfortable. So if you just kind of move them a little bit and they feel better, it's amazing. So it's just the true care of the patient, instead of being like, well, you've had a good life. Here's some phenobarb.
Go. You got a good life. Go. It's time for it to go.
Yeah. So there are treatments. There are conditions that are causing this, the desire to hasten death, and there are treatments for it. This was a very good article that I found a while ago. This is from 2005, dignity therapy, and they've done some studies on it. And it's really very cool. Like, you go through the person's entire life, and the therapist records the person speaking about it. Then they help them to put it into like a narrative, and they review their life, and then it gives them opportunities to resolve whatever hasn't been resolved, etc. And it really does help, and it really does decrease the desire to commit suicide. Okay. So then we have a few cases that we can discuss. So let me see. Okay, so this is the case of the vulnerable lady who has the daughter has suddenly become very vocal about her mother's right to choose. This is a person with dementia. It's an actual case. And I'll let this. So this is what the evaluating psychologist found, that her desire may be very influenced by the family's wishes, and the daughter may be somewhat coercive. So it's like, my mother has the right to choose to die. She deserves to die with dignity. And even a psychologist was able to say, no, this is, yeah. But she did. She was one of the cases. She passed in 85. Was it? No, she was 85. It was August of 1999. Okay, so
disease. So
she had Alzheimer's. So how do we know that she's making this decision herself? So we have patient autonomy, but is she being coerced? Patient autonomy, but is she conscious? Is she giving true informed consent?
She's capable to take.
Is she capable of making this decision? Right, when she's being coerced. So that's a big concern. And And another criticism that I have of the Oregon law is that there's no keeping track of this. There's no real keeping track. They report cause of death for her would be Alzheimer's.
No. What?
Yeah.
They do not report there wasn't a,
The death certificate does not say assisted suicide.
oh,
And like, for example, even
Because they
good
can't.
intentions of some people that have actually wanted to pass legislation for like, because that would be elderly abuse.
Absolutely.
Exactly.
When I was in school, that would be called elderly abuse.
And unfortunately, the state statutes on elderly abuse here in the state of Florida are atrocious in the fact that they are silent on what constitutes elderly abuse in these very nuanced methods, nuanced situations, where it's not like, oh, you have somebody and I want their money. No. It's very nuanced. The more nuanced it is, like maybe the daughter in this case wanted to take the homestead before the hospital attached a lien for treatment.
Mm-hmm.
Okay, they don't. The state statutes in the state of Florida are absolutely silent on that. You know, and I have to say, because I'm in the finance world, there is nothing for us to guide and protect the people that are our members and our clients. And
That's
we've
why
actually had-
directives are so important.
Yeah, we actually had a case recently where the person literally wheeled our member in the day before she died. We actually got notification at 10 o'clock the following day the person had passed away. And they were wheeling them
Making them sign
to
something.
make them sign.
We can sign.
And once, I mean, they're the only ones on the account. There's nothing I can do. I can have my suspicions. Well, okay, I'll refer it to the state of Florida.
Mhm.
The state of Florida says, is it or is it not their account?
We don't
Oh, it
have
is?
time.
And that's exactly what it is.
Yeah.
It's very sad.
So
very sad.
advanced directives, durable power of attorney,
Yeah.
Living will. Everyone has to have in black and white.
I just had one for my mom.
What do you want? What would that person want before they lose the capacity to make the decision? And then it's in black and white, and you can fight whatever you want, but this is what this person wanted. So as soon as I diagnose someone with a cognitive disorder or something, a little something starting, that's one of my spiels. You have to get a durable power of attorney. Who's going to make the medical decisions? Are you going to want a ventilator? Are you not going to want a ventilator? Are you going to want nutrition and hydration? This is the patient autonomy thing. They can say what they want or don't want.
You know, what I think I was sharing with Mary Jo, our church, you know, I don't want to put everything on them,
Mm-hmm.
but we do not inform the people. Advance directive, I didn't even know that.
Yeah.
I know it right here in the class.
Yeah.
This is why on Thursday, I pick up my mom, and then there's some question in the hospital. I said, I need that. And then I explained to my mom, what is it, stuff like that.
Mm-hmm.
And then, you know, I signed one. You know, I didn't know it.
And they have to do
That's
it.
who's gonna teach me.
Yeah. And for financial decision making too, like you were saying.
No.
And let me tell you, you know that when there's a vacuum, you know who's going to come in.
Mhm.
So there is a vacuum, and the Compassion and Choices people, previously Hemlock Society, they're the ones that are driving the physician-assisted suicide laws and wanting to get them in every state. They actually have groups that go to churches to be able to, they don't obviously say what they're doing, but they're giving education. So on advanced directives and doing all of this so that people are informed. Oh, and by the way, this could be a choice for you. Maybe if you bring it into legislation, you should think about it. So of course they're going to come in. They're filling that space that that we're not necessarily providing.
This happened in what state?
Oregon. Very at the very beginning,
I
99.
had a friend, she said, there's an expedition, so when we said there was a famous doctor in Miami, I
Mhm.
don't know what doctor, he has Alzheimer. 6 months, she had to check again the relationship. And the wife told her, oh, he's going to die in 3 days, being home. The wife get all the money from the doctor. The wife said, oh, yeah, I don't want him, I want to move for that. In 3 days,
He died at home.
She told her that my husband going to die in 3 days. And she died, she had to go back, I don't know, for everything. She died, he has Alzheimer. Here in Miami, yes, in Miami.
Mhm.
So you know what happened now. You go to a hospital, the doctor say to the my friend said, she's going to die in 3 days. So well, she was in hospital and she got with NPO and
Right.
morphine.
Yeah.
But in that case, the doctor was in the house.
Getting morphine and
I don't know.
IV.
She said there was a hospital people there, and but the wife told her she's going to die
Mhm.
in 3 days. So I go and do some papers on
Interesting.
Yeah, you know what they were doing.
and she did it. They did it. They said, yes, what we can do about this?
And the thing is, the church doesn't, okay, so if it's morally ethical to provide morphine and palliative care that may endanger the life of the person, that is still okay, because it's to alleviate pain.
Alleviate pain.
Once there's the intention of wanting to hasten death,
That's
then
it.
we're talking about something else.
Yeah.
And-
Not kill it.
Right.
So as a palliative, I mean, you want to make patient comfort.
Yeah.
It's another story.
Right.
They
That's
don't-
licit, and the church encourages it.
Okay.
And
Like
it, even though you know it may shorten the life of the patient, okay, that is not your intent. Your
That's not the
is to
intent.
relieve
So,
pain and suffering. That I was taught that when I was a medical student, and that's a long. We were taught that.
Yes.
You know, patients who were terminal and in pain, you have them, you know, we have them on morphine. Then we didn't have drips, we gave it IM, but it was always make sure now that the way it's written, the orders are written, that the patient is awake when the family comes in. So at least they can participate with the family,
Yes.
okay? And in those days, you didn't have visiting. And then as soon as the family leaves, as soon as they need something, you give it.
Yeah. And actually,
But
the
you give
religious,
only what they need.
yeah, and the religious directives say that the person also has the right to choose if they want to be conscious. If they don't want to be snowed, that's what we call it, snowed. If they want to be conscious because they want to go through the process of dying, even though they're suffering,
Yeah.
but they want to be present, they want to go to the sacraments, they want to, so you can give,
They titrate it.
you titrate it, yeah. But if it's a lot of suffering and
That's what
it
it's
could
called.
cause respiratory depression,
That is hospice, no? That's what
yes,
we're talking about.
that's hospice and palliative care, and it's
Okay.
licit and it's good and it's needed. And in fact, is an alternative
It's
to just saying, well, let's end the suffering by killing the person, right?
So doctor, I have a doubt, when the person is in hospital, who take the decision when it's coming from a hospital? So already from the hospital, they put an NPO and for a hospice candidate? Or when they go to the hospice, in the hospital, they say NPO and they do all the prescription for the patients. How I don't know, the process from hospital to hospice.
So in the hospital, they make the determination whether the patient needs or is a candidate for hospice palliative care. Then once they go into hospice, then they start their treatment. It's like a different treatment team.
So this hospital just follow the order from the hospital?
Not necessarily.
No. Actually, there is a different.
It's a
admission,
different team.
Even different admission.
Yeah, but is that, who decide that, for example, oh yeah, the,
No, the family and the patient.
Uh-huh.
normally in hospital, hospice. So for the
So
patient,
for any patient in hospice, hospital or otherwise,
Mhm.
the patient and family decide.
Mhm.
You discuss
You give
it
the
with them,
recommendation.
you let, you give them all the information, it doesn't matter whether the hospice is hospital-based or some other place-based.
Mhm. Or at
Okay?
home,
The
or
patient and the family make the decision. If the patient wants to go into hospice, the family doesn't have to be participating at all. But if the patient is not capable of making the decision by themselves, then the family, and according to the patient's directives.
yeah, no, but no, the thing is, who signed the paper about MPO number 5, morphine?
The
patient
treating
coming
doctor.
from the hospital, go to the hospice. So when
if
the
you're in
hospital
hospice, the treating doctor in the hospice
hospice.
is putting in the orders, yeah,
Mhm.
and deciding the treatment. But the patient has already decided and consented
To
that
go
they
to
want
hospice.
to, yes.
On the, okay, that the order coming from hospital to the
Or whether it's at home,
Home hospice is the same thing.
yeah, but it's a different team. It's a, the doctor, the nurse, the social worker. It is a truly beautiful line of medicine. It really is, if done well.
Yeah, exactly. So with
Unfortunately, even Catholic hospitals and hospice have been known to, push a little bit too much morphine and just a little, yeah. And then, and so that intent is the important thing.
Very important.
So, and people do, and it's tricky because sometimes people go into hospice way too late, and then they're in hospice 24 hours, and then it's like, oh, they killed him. But that's not necessarily the case. It's been actually studied that people accept hospice too late. So they suffer for a long time until they're like, okay, yeah, let's alleviate this, but then they enter into hospice and die very quickly.
Yeah.
Some people, because we're not supernatural, I'm not a psychic, I can't really say you have an expiration date. So some people enter into hospice care and it's 2 years later and they're still okay.
Yeah.
So there's, that's when you know that they're not pushing the morphine. Mm-hmm. And the case of Brittany Maynard is, everyone heard about this girl, 29-year-old, when too bad we don't have audio, but you guys can watch it's just a little snippet. And really my purpose for showing her is to also comment not only on the issue. Obviously, this was a 29-year-old who had brain cancer, very aggressive, untreatable, and she went on a crusade, let's say, right? She moved to Oregon to be able to get physician-assisted suicide, to be able to enact the death with dignity law. She had to move her family to Oregon. And it caused, I think it was an advancement for compassion and choices, because it was very moving, it was very emotional, it was a beautiful girl, and but from the psychiatric standpoint, which is what I focus on, obviously, excuse me, obviously someone with brain cancer is going to have mental status changes, right? That's one. So already I'm thinking, has this girl had a psychiatric evaluation? Is she depressed? Does anyone care? Anyone? Also, from her pictures from before and from this moment where she's, made the decision and is advocating for it, and talking about that, the last moments of her life, you can also, and this is speculation, this is
Yeah.
speculation on my part, you can tell that she's on steroids.
Which is part of the treatment for brain cancer.
Exactly.
Mhm.
And so she's
And there's those funny things that
puffy,
they're thinking.
And the steroids are, yes.
causes depression, suicidal ideation, causes mania, bad decision making, also the appearance. So she was a gorgeous girl, just married a year ago, weighed like 2 pounds, and now she's, her appearance is different, and that contributes to the depression. So to me, she's like, she's just like giving up, like, I'm not going to live like this. She mentioned something which is why it's so compelling, and it's so, you're on her side. She was having pretty severe seizures already. And so she didn't want her family to suffer through the seizures. And that she could look at her husband and say, I know this is my husband, but I don't know his name. So, and she's saying, I don't want to put my family through this. So then we think of the Catholic understanding. You're negating the opportunity of your family to care for you and compassionately love you through this. And so even the spiritual process of having a family member die is completely cut off by this, by the availability of physician-assisted suicide, because you're like the natural course of life, you're taking away that privilege of taking care of the person, right?
¿Cómo se dice? Soberbia?
Pride.
Pride, sometimes I think it's part of.
Yes.
I want to finish this as soon as possible because I don't want to see myself in this situation.
And or lose the dignity.
There's exactly.
Yeah.
I'm gonna change my face, my hair,
Yeah.
So
she's a proponent. She did go through it. She ultimately did end her life with phenobarbital. There's a million ways to look at this. There's many things we can discuss. In the case that I published a case study for the request for physician-assisted suicide here in Florida, where it's not legal, and the geriatric psychiatry point of view, and the really mentioning the difficulties with the law that maybe in this person in particular that I was treating, he had a lot of pain. He had prostate cancer that had metastasized to the bladder, and it was extremely painful, bloody, and just a very sad illness. But we were able to determine this person was not depressed. This person was actually in full, he didn't have a psychiatric history. He had symptoms of depression, but those were the symptoms that could be confused with just the medical illness. And he had a lifelong history of supporting Compassion and Choices, or the Hemlock Society. So he truly believed in physician-assisted suicide, and for him it was a rational decision. So, but of course, because we're in Florida and it's not an option, he was he was able to accept that, and obviously, because we weren't going to give him something for him to kill himself with. But we did other treatments. We did try antidepressants, and it gave him side effects, so it wasn't, we gave him antidepressants late in the course. When we first saw him, there was no evidence of actual clinical depression. So he had the suicidal thoughts and intent, but without the depression. So it was just purely the the physical illness and being uncomfortable. So what do? We palliate the symptoms. We, give him medication for pain, medication for the anxiety of that's caused by the uncomfortable issues with the Foley and the blood, and so it was very uncomfortable. And also therapy at bedside and therapy with the family, and the family had the opportunity to express, you're not a burden to us, we want to be here with you. So in that sense, that was a case where palliative care and really demonstrating that we're not going to abandon you, and we're going to treat whatever symptoms we can, and we're going to do the best we can to make you comfortable. The desire for physician-assisted suicide went away. So you treat whatever's going on.
Exactly.
It's very likely that the person will say, well, I don't want to really kill myself.
I want to enjoy my life. I think that the big thing is the comfort that somebody who's like this, who's ill, to get them to understand that no matter what it takes, we're here.
Mm-hmm.
That you really do care. That you never leave them alone. That
you're not a burden.
You don't have to constantly reassure, but show that you're not a burden. You show that you love doing this. Prayer does. I had my sister who had brain cancer.
Mm-hmm.
My best friend's mom. My own mother. Everybody was taking care of at home. And always, thank God we were able to. The only one was my dad, but he died in the hospital. But anyway, the thing is that they were never left alone.
Right. Because proponents would say,
oh yeah,
that the person has autonomy. You have to let them do whatever they want to do. It doesn't matter what you think. It doesn't matter but they're taking out that aspect. But what about the rest of the family? A suicide is
violence,
absolute destruction of the family.
Yeah.
It leaves behind the consequences are, So, and the slippery slope, the abuses that happen. I mean, in the Netherlands, or
well, when you think that in Germany they were killing all of the malformed children,
exactly,
until the word got out, and then they had to stop it. Now that's exactly what's going on in the Netherlands.
Yeah.
What's going on?
Infants, if an infant is born with whatever malfunction, genital or not genital, genetic, with genetic illnesses, or that they're, whatever, if something's wrong with an infant, they can euthanize right there. Huh? An infant
Euthanize.
already euthanized, yes,
Yeah.
because it's not a life worth living.
It's like at Athens, right? At Athens, when they have deformed through the babies, right?
Mm-hmm.
In Athens, the Greek culture.
In many cultures.
Spartans, right? Spartans.
Yeah, many ancient cultures. And also there's the slippery slope of the abuses that the family doesn't find out. And, the doctor just decides and euthanizes the person, and the family never finds out.
Scary, because I always say, okay, congenital, you can see it. You can now detect even genetics problems inside the womb.
Oh, yeah. Oh, that's...
But once we start discovering all the psychological, mental, psychiatric things, who's gonna live? They want to kill everybody. You know what I mean? Once you find any genes that are gonna tell that you're gonna have a psychosis or any psychological mental illness,
a life not worthy of
So you can
living.
decide you want to have a kid like that or whatever. You know, and it's speculation and maybe I'm exaggerating. But
No,
with technology, we find
That's where
a
it's
lot
going.
of stuff.
That's where it's going.
it's
Yeah, you
already
do it.
happening.
What you do if somebody has the gene for Huntington's, your baby in utero
Yeah.
has the gene for Huntington's chorea, which does not show up until you're in your late 30s and 50s. Okay, so for those 30 or 50 years, you're taking that life away
Mhm.
because they might have it, they will have it at 30 to 50.
Oh, it's even scarier is that have you guys seen the commercial for the they basically do a genetic workup on you.
Yes.
And my question is,
And
where
anyone
do they
can get
keep this data?
Uh-huh.
Because they send you a copy.
Yeah, but someone
if they
has
send you a
it.
copy, I have to have a copy.
Of
So what
course.
do? Do I sell it to the insurance companies?
It's a database, of
Do I
course.
sell it to the government?
Of
Well,
course.
there's a database out there, don't you ever
No,
worry
I know
about
there
that.
is, but believe me, I know, but
Yes.
it's kind of like being normalized.
Yes. So that you can,
Know
Take
what you're
care
up
of it,
to,
yeah.
You know.
yeah. And what's another abuse and slippery slope issue? It's already starting to happen in the US, but in those countries already, mental health used to not meet criteria. But now you could have been suicidally depressed and intractable, so not responding to treatment, and people have been protecting you from killing yourself for many years, and all of a sudden now it's like, just go ahead and do it. Now we're going to help you. How does that make sense? So that's the slippery slope. That's the
Well, I hate to say it.
yes.
There's one other effect that nobody seems to be applying. The longevity and the effort to maintain the longevity of life, just as at the beginning of life, means that anything new that comes up that otherwise would be cured is no longer being faced or challenged. So therefore, the new cures that have extended life from the beginning and the end are removed. And neither the people that are supposedly being compassionate without really thinking about it, but being very selfish, nor do the people that have an agenda realizing that in turn will come back and affect them. It'll bite them in the butt for sure. And that's one of the arguments I have every time when we talk about this kind of issue. Forget about the fact that, yes, I understand everybody has difficulties in living, but it's the effort to help people survive that always brings about the betterment. And it brings families together when people are challenged, reversing the issue and the concept of, hey, let's just take care of it. It's easier. And that's what I think our society has gotten away from. It's easier, try it that way, forget about the work.
Absolutely. Yeah. Absolutely. Thank you. So, and along those lines, I did have, when we had a Catholic bioethics conference here in Florida, the Florida Catholic Medical Association bioethics conference, we have one every year now. This little handout here with the questions came from someone who's actually a lawyer, and he actually trains physicians and people like in Respect Life Ministries and all of that, how to respond to these ethical questions, and specifically that this is regarding physician-assisted suicide, and to be able to be interviewed and be coherent and not get all passionate and then you're called a religious freak, to be able to really respond. And so I thought that it would be neat if you guys want to go through some of these and discuss what you would answer, right? Because do we have time? We have time? Yeah. Okay.
11:30.
Yes.
So some of the questions that you would be asked, and kind of trying to bait you into into going to the other side, right? Doctors are helping patients die now by prescribing medications that can be taken to end life. Why are you against a law that brings this out of the shadows and establishes guidelines that would provide safeguards and protections? What would your answer be to that? My answer, to begin with, it does not provide safeguards and protections. There are no safeguards in any of these laws. That's one of the biggest criticisms. Mm-hmm.
I would say that I didn't create people. I cannot take people's life away.
Mm-hmm.
So, and I cannot assist no one to kill themselves because I'm not gonna go to hell.
Yeah. It's not my
fate.
It's not my responsibility. It's not my. I'm not gonna be responsible for someone ending their own life.
Yeah. Yeah. And then according to the Bible, I don't recall the verse, and Jesus saying that, you know, he said, if you let your brother, if you cause your brother to do a sin, you are responsible for it. Mm-hmm. So I'm not gonna go through that, you know. Mm-hmm. So maybe I can slide that in there. Mm-hmm. I'm not responsible for your sin.
Yes. Yep. Even though you may think it's not a sin, mm-hmm. I do, and I'm opposed. and you have to respect my opinion. I respect yours. But we do think it is sinful to help someone die, and therefore we're opposed to any legislation of this sort.
I would kind of turn it on itself. I would give you the same question and say, well, I understand your point. You're saying that you're bringing the process out of the shadows, but specifically, what safeguards and protections are you referring to?
Right. And have them.
And then I would clam up.
Uh-huh. That's very important. Yes.
And wait for them to tell me what safeguards and protections there are.
Exactly.
Because they're not.
Yes.
I would think the other thing that you have to ask too is, how do you feel about it? Because you're going to find that they, in their own lives, have that challenge in their minds to say, how do I want to deal with this? So as Catholics, we avoid, which was spoken of earlier in one of the classes, we avoid the concept of death and what happens and the transition and the fact that death is not a horrible thing, even if the process is difficult. We just have to teach more people that it is a process, not an end.
Absolutely. That's a great response. Anyone else would have, excuse me, anything to say about this one? No? Let's move on to the next one then. So I do not want to die in a hospital, hooked up to machines, and unable to talk with my family. If you want to die that way, that's your choice. But why are you against my being able to take a pill and sleep and slip peacefully away?
It's really the same answer.
Yeah. And I would add, physician-assisted suicide has nothing to do with dying hooked up with machines in a hospital. It is completely moral and licit to withdraw extraordinary measures of care and let the person die. We're not in the business of keeping people alive with machines. The decision is made, you withdraw care, and the person dies peacefully with palliative hospice. You know, you help them through. It's not. That's why I mentioned in the talk that they're really separate subjects, but they're being mixed into it. So people have this idea that doctors just want to have me hooked up in the ICU forever so that they can keep billing. But no one wants to do that. No, we want to let people die, you know, peacefully. So physician-assisted suicide has nothing to do with that. Me being able to provide you with some phenobarbital so you can commit suicide has nothing to do with ventilators and what we call extraordinary measures, right? Okay. Anyone want to read the next one?
I'm dying, I don't want to be a burden to my family. Why do you deny me that choice to have aid in dying? Because you're depriving your family of walking with you on this journey. I'm giving you love and loving you through it.
What do you think, I will ask, what do you think you're a burden for your family? Somebody has told you that you really, you really listen complaints about it, I mean, that's what you feel. Have you talked about that? I mean,
Exactly.
how do children feel about this?
Yes.
Well, just what it said, it complements the other process. If we always look at it as something disdained, something that's kept off from a distance, how do we embrace the process ourselves and our children, just as was mentioned, in the future? So we're creating a culture of death is terrible, death is an end. And that's what the process is. People need to be at the hospital with the parents and the grandparents. People need to be in the home when they're going through the finality of this, and have to give the extra care and the support. We're always in such a big rush, we forget about those moments of support that are necessary.
Exactly, and that are a part of the grieving process.
Exactly.
So you're actually depriving your family of going through this and being able to have, closure and healing, and absolutely. And I would also say, why would you deny me the choice to have aid in dying? I would say I'm not denying aid in dying. We're going to help you to be comfortable. That's aid in dying. That's aid at the moment when you're dying. It's just, I'm not going to push you over the edge. And so I'm not going to cause death. I cannot be a culprit in causing your death. I am not denying care. That's it. So see how the wording is
The wording is very important. Yeah.
very tricky.
Very
No, it
tricky.
is not a denial of aid. It is not. Okay. Someone else want to take the other one?
Yeah, you made it clear that you oppose this bill. Will you work together with those of us who want this end of life option so we can make it acceptable to you? Work with you, but you're not going to make it acceptable to me.
It's never going to be acceptable.
I will work with you, but it'll never be acceptable.
Because what they're trying to say is there some wording we can change here? Is there something we can put in here that'll make you feel better? Are there some safeguards that we can say we're going to put in? No. It's a hard no. The answer is always going to be no.
I'm hoping all the time I'm working with you, I'm going to get you to change your mind.
Exactly. Yep. Let's see, what's the next one?
How can you bring up all kinds of possible abuses and problems with the Death with Dignity Act? It is much like Oregon's Death with Dignity Act. And more than 18 years of experience with the law in Oregon has shown that those scare tactics are false. In Oregon, in dying is working well with no abuse.
How do we know that?
We actually know there are abuses.
Oh, really?
Yep.
But we also know that there are people who are given the pill that they would do it at home that never ever.
You don't find
take
out.
it.
Yeah.
Oh, really?
Or you take it, or they take it and you don't find out that they died because of it. And like the case that I presented, the 85-year-old lady that, I mean, if that's not abuse, I don't know what is. And she ended up being one of the people that enacted the law.
Yeah.
So there are abuses, absolutely. And I would consider it abuse to not have a psychiatric evaluation
Exactly.
to and at least see if the patient is competent. Not competent because that's legal, but to see if the patient has capacity. And they don't. And the law says it may be, and you'll see it, I think I quoted it in the article, it may not be good to consult a mental health worker because they're usually going to say No.
How is the process about
The same happens with the abortion. They don't do the ultrasound because they know the mother is gonna say, no, I don't want to.
but how is the process about a suicide assistant? So they give the pills and then they have
Yes.
to report that the person died that day, or they decide later they can keep the pill for the other things, and after they die the person from other things. How is it? How is the process?
The process is the person, at least in Oregon, which is the one that I know
Yes.
the best because it's the one that has the most experience, the process is the patient expresses the desire for physician-assisted suicide.
Mhm.
The doctor then says, okay, that I'm going to evaluate you. Yes, I think you're a candidate. And then a second doctor has to give, they have to get a second opinion. There is a wait period. There's a certain amount of time that you can't just decide it today and then get the medication tomorrow. So there's a certain amount of time. Once the second doctor, who is never going to be a psychiatrist, says, yes, this person is a good candidate for the act, then they're prescribed phenobarbital. So, and it's usually liquid, I believe. And that's another thing, the pharmacies. What pharmacy, if you were a pharmacy owner, gosh, you're prescribing something that you know what it's for.
Oh, yes. I mean, this is a
You're
chain of-
prescribing a lethal, you're filling a prescription. So the person goes to the pharmacy with the prescription. The pharmacist has it in stock, something that used to be a medication for seizures and now is used for physician-assisted suicide. And then it's either liquid or liquid gels that the person has to prepare. And then you take that home and you have it for whenever you want to use it.
Whenever. So they can use that for kill the person.
Exactly.
Yeah.
They can do what?
To kill someone else.
So because nobody pushed them to say the truth in the death certificate.
Right. Right.
So,
So for the person who asked for it, now they have it at home and they can use it when it's convenient for them. And then now obviously then the new practice is to have like a family gathering and,
so the doctor doesn't need to be there present when it happens this.
No.
As soon as I prescribe you.
no. And it's also been reported that it's not that easy. And a lot of times people actually don't die. And then Compassion and Choices is there. They have a representative. So this is the organization that's pushing for this. And they help the person to die.
I thought,
I don't need to help the person to die.
Exactly.
I thought that when you just say it's
What is that called?
It's called a coup de grace in the military. I mean, I'm sorry.
That's murder.
Yeah.
So, or they tell them, okay, well then put a bag over your head, or get this going. It's been, and these are, this,
Nobody controls the medication.
no,
Because
That's outrageous.
they can use one, they leave the other, and then after they can.
Yeah.
put it in.
and then once the person dies, the cause of death is their terminal illness. It's not suicide.
That's somebody strangled you.
Or somebody strangled you to help
Somebody
you.
put a pillow over your
But
face.
here in
Right,
the United States,
right.
doctor doesn't sign
Or they
that.
throw up and then
Yeah,
aspirate. And,
But the doctor doesn't sign that.
Wow.
They terminate the death. Doctor has to be signed that here it's not like that. Here in the United
No,
States.
what if they break down Alzheimer's?
That's
Yeah,
what we're gonna run.
But for example, when I was in my country from Peru, so it was a person who died,
mhm,
and then they did with purpose. So the doctor knew that.
mhm.
So he didn't want to sign the death certificate to put it why she died.
Uh-huh.
But that's what I know. I didn't know here doctor doesn't need to say once this patient died from this.
No.
So that just the person goes
So-
to the death certificate and says this person died from
In this
this.
case she's talking about, in these cases.
In the
Don't get
states,
lost in the fact that it's done for
in the
everything.
states
No,
where it's
only
legal, yes, they don't
Cases
have to.
where it's legal.
Yes, the doctor does not have to be there,
This is suicide.
Okay.
and they don't have to report the cause of death as suicide.
Oh,
It doesn't have to be there. As soon as I prescribe you the medication to die, and then
They
go
take the
away.
medication themselves.
Isn't that insurance fraud then?
Yeah, that's a good one.
There's so many levels to this. That's why I was like,
No,
we
but
could talk
it's
for hours.
Insurance fraud, because if you commit suicide, you are not
Exactly.
supposed to get life insurance for this individual.
Right, right.
Oh,
I think that's written into the law, though, very conveniently. I think they were dealing with that, of how insurance could get out of it, but then obviously Compassionate Choices wouldn't want that. They would be like, no, this isn't real suicide. This is
Oh, you put a pillow on the
exactly.
So in that case, yes, it is a suicide.
In that
I don't want to
case,
take that word.
no, I think it's written into the law that they died because of, let's say, Alzheimer's. It wasn't suicide, it was the Alzheimer's that killed them. So the life insurance has to pay.
So there was a case, in New York, I think so,
Mhm.
that insurance doesn't want to pay too much. And I think they was realized it was a noble something in New York hospice.
Mhm.
It was penalized for the government because the insurance proved that they were telling nurses to faster the medication to give and killing the patient fast because they don't want to be
Because they don't want to pay for the
hospice.
hospital care, of course.
Yes. So, but that insurance make the claim selling too many of these patients going too fast, and they
Yes.
didn't pay the. Yeah, it was a noble. They closed the hospice.
Well,
in New
yep.
York.
And we have another comment?
Yeah, I would think that the quickest way to get this to slow down a little bit is to start raveling the insurance companies. The people that start killing their relatives.
Yeah, tell them the company, say, yeah,
Exactly.
you don't have to pay, so they
Hey.
fight for us.
It's just, yeah, I mean, like I said, there's so many levels to this that it's
Yeah,
just,
so you just show them money.
it shows how unethical it is to begin with, right? If it brings up all these ethical issues, it is not an ethically sound practice. And I thought of another one too. Oh yeah, there are cases already in Oregon where a terminally ill patient was denied care by the insurance company, by the medical insurance company. But, so you have this type of cancer, there is this treatment, but we're going to deny that treatment because you're going to die anyway. But we can offer you physician-assisted suicide.
Wow.
Those are real cases that is going on right now. So the medical insurance company denies care, but offers assisted suicide as a treatment.
So if the patient has an insurance line, we can take the insurance lines to go against that,
Yeah,
and they
my
don't,
ethics degree.
because they fight for that, for money.
The insurance companies love it. The medical insurance companies love it because it's like, well, I don't really have to treat you, right?
Yeah,
You
but
can
the
just,
insurance line, they don't like it.
oh, they do that all the time. That's like regular practice for them. They deny care all the time.
Oh, yeah.
But not only can they deny care, now they're like, but wait, there's more. We can offer you physician-assisted suicide. It's only like $800. We'll pay for that.
Wait, but is the adjuster a medical doctor license?
Of course not. It's an insurance company making a determination.
But
Yep.
according to the law, do they have the right to do that? According to the state law, whatever
Well,
state they are.
those are the things that are being dealt with now. So it was a lawsuit.
Right.
So number
There's several cases where people are demanding care.
Don't offer me physician
That's not
suicide. I
right.
don't want that. I want care.
A strategy in a legal strategy is to just file lawsuits and continuances. A continuance if the person has cancer. Cancer is not something that takes 10 years. Cancer can take, weeks to months.
Yep.
And after the patient's dead, oh, your case is moved.
Oh, well, yep. So it's really, I like the term slippery slope because it is. And we're way down there already. It's not even the only thing left here is euthanasia, like legalizing euthanasia in the US. So So do you want to go through the rest of them, or my talks are usually downers? This is like not a happy subject,
Yes.
and usually my subjects are not. But we do know we have hope, right? I mean, that's what I'm holding on to. I believe that we have hope, that we know who won this battle, right? Because this is all bad news. I'm usually the bearer of bad news in this kind of thing. But so do you want to continue, or do
Look at
you?
number 8.
Mhm.
We don't know what it's like to have a severe disability. My brother can walk, can drive a car, and can even go to the bathroom by himself. Would you want to live like that?
My answer is, what does your brother say? What does your brother say?
Is his life worth living?
So what do you want?
Yeah, why are you doing this? What does your brother say?
Mhm.
Does he say he wants to live like that? Does your brother think his
That's
life is
your-
not worth living?
You're projecting on your brother.
Exactly.
You don't want to deal with it.
You're projecting what you feel.
I mean, I have a friend who has horrible cerebral palsy. He cannot even bless himself. Okay, that's how bad it is.
Mhm.
And his mind is super, super, super sharp. And if you ever say to him, Jamie, would you like to die, or would you like to give up living like this? He said, my life is fine. You know, I wouldn't have chosen this, but no.
Yes.
So, but do you see that physical is very famous? Cannot talk, he has a disease and he's
Yes.
shrinking. I think he used his brain and he used some machine. And he still continued living. He has 3 wives, is it? Right. I don't remember. It's a very famous physicist.
Are you talking about
Dawkins?
Physical. It's a physical. I
a
don't know.
physician?
Krusher, that's in Germany.
Oh.
He's very he proposed something about. You know what I'm
I'm
talking
trying to
about?
think about it.
He's not the famous atheist.
It's a physical.
Well, he
Physical.
denied the existence of God recently. I'm trying to think. He wrote the book.
Yeah, he said
Beginning
that.
of Time.
Oh, you're talking about that super
Superman.
scientist.
Yeah.
Oh, he's crazy as hell.
But he doesn't know anything. He's still alive. He wants to live and do everything.
Right. His life is worth living.
Yeah,
Right.
but he has a 3 wives. He has 3 wives.
Uh-huh.
Right.
Yeah.
Right. So then the question is, who decides?
Stephen Hawking.
Stephen
Hawkins,
Hawking,
right.
yeah.
Okay.
Who decides what life is worth living or not?
Yeah.
And that's in the Netherlands. It's
The doctor decides, or somebody else.
Exactly.
Not the person.
the doctor decides. And actually, EWTN had a really good documentary, and it has a lot of people giving their testimony from the Netherlands, and one family had a disabled daughter and other kids. They were like, let's say 5 kids, and one of them was disabled, and they go to the park and everything, and this family is actually constantly berated by other people saying, why don't you euthanize her? And they're like, are you telling me to kill my child? We're not going to euthanize her just because you are uncomfortable with looking at her. I mean, it's very,
Wow.
yes.
Oh, yeah.
So people, strangers
Yeah.
are like, why are you doing this?
Well, it was tried in history.
So wash brain.
Yes.
That's
yes.
from the Spartacus in Texas. They were warriors,
Mhm.
and the moms pushed the children to go since 10, 9 years old to be a warrior.
Uh-huh.
And they coming back want to be
Yeah,
the mom. They don't want just
Brainwash.
they're so proud. They want to be. They die for the country ever since. So.
Yes. Oh yeah, it's a cultural,
They're going back to the old ancestors. Like,
Number 6, that's what somebody would told me. Why are you trying to impose your religious belief on me?
that's something that you have to be able to respond to. We're mentioning number 6 for the people online.
I respect your right to die the way you want, but I don't understand why you won't respect my right to choose a dying. Where are you trying to impose your religious belief?
Right.
Well,
And we've determined here it's not necessarily even religious.
Exactly.
Right, why
It's-
would you force me to participate in something that I don't believe on,
Morally.
just morally
Exactly.
to quell your thirst for whatever desire?
But it's what she says,
Your
not only
rights
the people
end at
with
mine.
religious, it's people with, not necessarily have to be religious.
There's atheists against physician-assisted suicide and euthanasia, absolutely, because it's not necessarily a religious issue. And that's what we want to really train people and have you be able to respond in a way that, unfortunately, we are living in a time when you mention religion and people are going to be like, oh, I'm not even going to listen to you. So we have to be able to have this conversation in a secular way and rational, because it is, because it's the truth. And we can argue it rationally without, if they don't want to hear about religion, then that's, unfortunately, that's where we are, but we do have to be able to discuss it in a way that's rational, and that we can say that this doesn't even have to do with religion. This is a matter of having good medicine, having good insurances, paying necessary treatments, having good doctors who can say, we're going to withdraw care because it's time, versus let's put this patient on a ventilator forever. Like, all of those different levels have to be addressed and said, like, look, this is good medicine. This is not good medicine. So that's rational and non-religious. Okay? All right, well, thank you for listening.
Thank you.
And we have Our Lady. We will pray for everyone too.
Thank you, my fellow classmates.
Thank you very much.
You're welcome.
Great conversation.
Thank you.
Sandra,
Yes.
can you give me the name of a Catholic licensed clinical psychologist?
Yes. I have a list.
If you can, because
I have a referral list. Okay, so I'm going to stop recording. I hope this all worked out.